Coming up in this episode, it's pretty hard to examine for anhidrosis, but the pupil is the key. So you should have a small pupil, miosis. Whereas in a third nerve palsy, you should not have meiosis. And conversely, if it's what we call a surgical third nerve palsy, then you get the opposite. You actually get mydriasis or a big pupil. And classically, that's because the fibers in the third nerve that control the pupillary muscles are located on the outside aspect of the nerves. Hello, and welcome to the next episode of Risfeld Neurology Education, a not for profit, free open access project with a philosophical touch exploring all areas of clinical neurology. I'm your host, Tom Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. Today's installment is on the cranial nerve examination, the theory behind the examination. There'll be a separate episode with a practical demonstration later. And in particular, it's going to focus on pearls and pitfalls that I've developed over the years. And the reason that I'm bothering to give this presentation, acknowledging that it's pretty easy to find various textbook chapters and internet websites and videos and lectures on the cranial nerve examination, is I've seen it done in many different ways, and I've seen it done well and I've seen it done not well. And there are quite a few traps that you want to avoid, and it can be difficult to remember it all as well. So I'm hoping to teach you all how I see the cranial nerve examination, how I approach it, how I remember it, and the good techniques that I would like to communicate to you, and also things to avoid when you're doing your cranial nerve exam. So without further ado, let's dive into it. And a legal disclaimer before we begin: the content of this episode is for educational purposes only. So I'll begin just with an overview of the cranial nerves and the components of the cranial nerves which are amenable to examination, although this won't be an anatomy video, but I do just need to start with this. So there is quite a rude mnemonic for remembering the actual names of the cranial nerves. If you know it, you know it. If you don't know it, then you'll have to Google it, because I will be kicked off YouTube and off Spotify and off all the audio podcasting platforms if I were to repeat it. But it begins with OOO, to touch and feel, and I can't go beyond that. And there's also a separate mnemonic with both rude and less rude versions for remembering whether the cranial nerves are just motor or just sensory, or both in terms of the function that each cranial nerve has. So the not so rude version is: some say marry money, but my brother says big brains matter more. So again, some say marry money, but my brother says big brains matter more. And the first letter of each of those words starts with either an M, an S, or a B. M is for motor, S is for sensory, and B is for both. And the slightly ruder version of the mnemonic is exactly the same, although it substitutes brain for a different body part that also starts with B, and you can use your imagination there. So in terms of the components of the cranial nerves which are amenable to physical examination, first I'll go over them, each cranial nerve at a time, and then on the next slide I'll describe how I conceptualize them in my mind so that it's more pragmatic for an examination purpose. So firstly, the first nerve, the olfactory nerve, is smell, and so you can examine smell. Secondly, the optic nerve is for fundoscopy, acuity, fields, and color vision. Next is a combination of the second and the third nerve, the oculomotor nerve, and that's for pupillary light reflexes and accommodation reflexes. Next is the third nerve alone, and that's for ptosis. Next is the third, the fourth, and the sixth nerves. So the third nerve, then the fourth, which is the trochlear, and the sixth, which is for extraocular movements, including testing for an INO, an internuclear ophthalmoplegia, and also saccadic testing. Next is the fifth nerve, the trigeminal nerve, and that's testing facial sensory and some components of motor function, along with the jaw jerk and the tongue's somatic sense, so not the taste sense, the somatic sense, to the anterior two-thirds of the tongue, ipsilaterally to the side that the nerve is on. Next is a combination of the fifth and the seventh nerve, the facial nerve, testing the corneal reflex. Next is the seventh nerve alone, which tests motor function of the other facial muscles, along with the taste modality to the anterior 2/3 of the tongue ipsilaterally. Next is the eighth nerve, the vestibular cochlear or the auditory nerve, which examines hearing and is further examined with Weber's and René's test and also tests of vestibular function. Next is the ninth nerve, the glossopharyngeal nerve, and that's for taste and also the somatic sensation in the tongue, both in the posterior 1/3 of the tongue, ipsilaterally. Next is the ninth nerve and the 10th nerve, the vagus nerve, and that's for the gag reflex, along with uvular and palatal movements and positions. Next is the 11th nerve, the spinal accessory nerve, and that's for shoulder shrug and head rotation strength. And then lastly is the 12th nerve, the hypoglossal nerve, which is for tongue movements and positions. And then a combination of the 9th, 10th, and 12th nerve, or the bulbar nerves, including the 11th nerve, which doesn't control this function I'm about to tell you. Also with a combination from the 5th and the 7th nerve is speaking and swallowing, so testing for dysarthria and dysphagia. Now, many of the components that I've just listed are routinely examined in the cranial nerve examination, but some components honestly are not very helpful most of the time, and so you don't need to test them routinely, and you only need to test them when they are specifically clinically indicated. And if you're watching the video, I've indicated this with colors. So orange is sometimes indicated depending on the clinical context, but is not uncommonly performed. So that includes fundoscopy, color vision assessment, INO and saccadic testing, and vestibular assessment. Whereas the components which are even less often helpful, in my opinion, and are not often tested, apart from in select circumstances, are smell, accommodation pupillary testing, jaw jerk, tongue somatic and taste testing, the corneal reflex, Weber's and René's test, and the gag reflex. So, in terms of how I would recommend routinely grouping the nerves together, including all of the components to begin with, I would turn first to smell. Then I would turn to the second nerve, focusing on fundoscopy, acuity fields, and color vision. Then I would group the second and third nerve together in terms of pupillary light and accommodation reflexes, and also ptosis testing. Next, I will group the third, fourth, and sixth nerve together in terms of testing extraocular movements and testing for an INO and saccades. Next, I like to group the fifth and the seventh nerve together in terms of testing facial, sensory, and motor function, and if indicated, a jaw jerk, tongue, somatic, and taste sensation to the anterior 2/3 and the corneal reflex. Then 8 is tested on its own with gross assessment of hearing, followed by Weber's and René's tests if indicated, and vestibular assessment. Next, I examine the 9th, 10th, and 12th nerve together, focusing on uvular, palatal, and tongue positions and movements, dysarthria, dysphagia, and if indicated, then the gag reflex and taste and somatic sensation to the posterior 1/3 of the tongue. And finally, I examine the 11th nerve for shoulder shrug and head rotation strength. And then if we minus out the rare components, this is how you get your more efficient way of examining. And I'll come back to this at the end just to demonstrate that it can actually be done quickly and in an efficient manner. So let's actually dive into each component of the examination in detail, and I'll explain how I would recommend examining and how I would recommend not examining each nerve. And I'll try and indicate how it's clinically relevant, and hopefully that will really help reinforce this knowledge so that you can actually remember it. So firstly, the first nerve, the olfactory nerve, really you can only examine smell, and this is an isolated sensory nerve. The ways in which you can do this is firstly by, realistically, it's unlikely that you're going to be walking around with vanilla essence in your pocket and lots of different forms of smells. But in a hospital setting or in an outpatient setting, there's generally going to be some alcohol-based hand rub. So that's something that you can just put on a piece of tissue paper or on a glove or on your hand or something and see if the patient's able to smell that. You can try and test each nair individually, but I don't think that's very helpful because it's pretty difficult to isolate one nair and then the other. And how can this sometimes be clinically relevant? So, firstly, if there's any pathology affecting the cribriform plate of the ethmoid bone, such as trauma or an abscess or some form of tumor, then that could invade into and affect the olfactory nerve. Other ways in which smell can be affected realistically in daily neurology practice is in the context of Parkinson's disease or some other extrapyramidal syndromes where hyposmia or anosmia are often seen. And also with the somewhat recent, although not that recent now, COVID-19 pandemic, that was also a common cause of anosmia. Moving on to the second nerve, the optic nerve. So, firstly, fundoscopy. There's a few tips that I give here. Firstly, practice, 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 practice. It took me quite a long time in terms of routinely performing fundoscopy to get the hang of it. It probably wasn't until I was in the first year of my neurology advanced training and I was doing fundoscopy on a daily basis that after probably 3 or 4 months I started to get the hang of it, and maybe in the back half of the year I felt competent and comfortable, truly comfortable with my fundoscopy. So it really does just take time. So it's good to get into the hang of practicing fundoscopy whenever you can, and the skill will come with time. In regards to the equipment to use, there's the classic handheld direct ophthalmoscope, which doesn't have the panophthalmic lens, and they're much cheaper, although there are still budget versions which can be acquired for about 75 Australian dollars, or more expensive versions which are 300 or 400 Australian dollars, and they're completely adequate. Some people find them difficult to use, but it's what I've always learnt to use and they work perfectly fine when you know how to use them. Conversely, there are the panophthalmic ophthalmoscopes, which have the advantage of covering the eye to make it darker so that you get a greater degree of pupillary dilation before you start shining the light in the eye, and you can get better fundal views. They are used differently, however, and if you don't know how to use them, they can be difficult, and I'm not very familiar with using them because I don't own one and I don't use them often, so I actually find them a bit difficult, but you do get very, very, very good fundal views when used correctly. However, they are very expensive. They're about 1,600 Australian dollars. In terms of pro tips into how to see the fundus well, firstly, have a dark room. A dark environment really helps. The other thing that really, really, really doesn't help your attempts at fundoscopy is if the front of the eye is wet. So if the patient's a bit teary, or more likely if you've been trying to shine the light in their eye for a long time and they've developed some tears, then the tears on the surface of the eye seem to reflect the light. And so you just shine the light in the eye and you get this reflection of light straight back at you, and you can't really see through the pupil, through the body of the globe and into the retina. So that's not very helpful. So if that happens, what you can do is you can just ask the patient to blink a few times, give them a bit of a rest, go to the other eye and then come back to the first eye. Or you can get a little bit of tissue paper and just ask them to dab their eye to try and get some of the water to go away. The other thing that can be tricky is if the patient has some cataracts, and so sometimes you need to try and maneuver around the cataracts and come at it from a different angle to try and see around or behind the cataract to get through to the retina. And the other thing which is obviously difficult is if the patient's closing their eyes or moving their eyes about or shifting their focus. So I've heard different people recommend different things in regards to where you ask the patient to look. I usually just ask the patient to look at something straight ahead or relatively straight ahead and try and fixate on that point, and just try not to move your eyes around too much and try not to blink too much and try and keep your head still, and then you just go for it basically. You also need to have the ophthalmoscope very close to the patient's head and very close to the patient's eye. And so what that means is when you're examining the patient's right eye, you need to use your own right eye so that your lips are off to the side of the patient's head and not right in front of the patient's face. And conversely, when you're examining the patient's left eye, you also need to use your left eye so that you're not clashing heads with them. And you do need to be really quite close to the patient, and the ophthalmoscope needs to be right up against your own eye. I wear glasses normally, and I'm sure lots of you do as well. And some people try and do ophthalmoscope whilst wearing glasses, but I would really recommend against that. I've tried it. I really just don't think it works. I would recommend taking your glasses off and then just changing the dial on the ophthalmoscope to accommodate for your own refractive error. And then if the patient also has a refractive error, then you'll need to change the dial some more in one direction or the other in order to accommodate for that as well, in order to get a clear focus on the patient's retina. If you're moving the dial through many, many different settings of refractive correction, then you're probably not on the mark. It usually only takes a few corrections in one direction or the other in order to get there. Then, in terms of what you're actually looking for when you're doing fundoscopy, the way I see it is there's the neurologist or the everyone else level of fundoscopy, and then there's the ophthalmologist level of fundoscopy. Ophthalmologists can look for all sorts of things. I can't do that. What I'm really looking at is the optic disc and the optic disc margins, because what I'm interested in is there any blurred optic disc margin suggestive of papillitis or of papilloedema? And is there any optic disc pallor? They're mainly the things that I'm looking for and that are relevant most of the time, in addition to a few other things which I'll mention shortly. So, how do you actually find the optic disc? Well, you find the retina, you then find a blood vessel, and you track the blood vessel in one direction until it ends up at the optic disc, and then you found it. And then you're really looking at the margin of the optic disc, and it should be quite clear circumferentially. It's usually a lot easier to see a clear disc margin on the temporal aspect of the disc margin, and I usually find it more difficult to see a crisp disc margin on the nasal aspect. But if you try hard enough and focus hard enough and long enough, you should be able to see a crisp disc margin circumferentially, and that's quite important, and it should be seen bilaterally. So, if you see a blurred optic disc margin, what does that mean? Well, it can be papillitis, so that's swelling of the optic nerve head, so the anterior optic nerve in the intraocular or intraorbital compartment of the nerve, which causes a blurred optic disc, and that's usually going to be unilateral in most cases. Not always, because you can have bilateral pathology, but a lot of the time that will be unilateral. And that's going to be caused by an optic neuropathy, using that as a broad umbrella term to encompass a number of etiologies. And that classically in neurology would include optic neuritis, classically an inflammatory optic neuritis, which is what we normally think of when we think of optic neuritis, which could be either a clinically isolated syndrome, not in itself diagnostic of multiple sclerosis, or it could be a demyelinating episode in the context of someone who has multiple sclerosis. Alternatively, it could be infective, or it could be an ischemic optic neuropathy. And they are further divided into arteritic and non-arteritic ischemic optic neuropathy. So, arteritic ischemic optic neuropathy would be classically in the context of, say, giant cell arteritis or some other systemic or localized inflammatory condition, a vasculitis affecting the blood vessels, but that is then in turn causing ischemia to the optic nerve itself. So it's inflammation, but it's inflammation not in the nerve, it's inflammation in the blood vessel supplying the nerve, so that the nerve then becomes ischemic. Or it could be non-arteritic ischemic optic neuropathy, so that would include atheromembolic, small vessel ischemia, and the like. Conversely, papilloedema also causes blurring of the optic disc margins. However, that is usually a bilateral process, and it is by definition in the context of raised intracranial pressure, ICP. Secondly, we're looking for optic disc pallor. And what does that indicate? Well, it really just means that there is optic nerve atrophy, and that can be caused by essentially any of the above optic neuropathies that I've just mentioned. And it can also indicate that the process is acute, although already somewhat advanced, because it's bad if you have optic disc pallor, especially in an acute phase, or it could just be chronic or a residual finding from a previous insult. So, for instance, if you have a patient with multiple sclerosis and they've had optic neuritis on one side in the past, and they may have optic disc pallor, which may be residual from a previous attack, it may not be indicative of an acute attack, but it can sometimes be difficult to distinguish them apart. The other thing that you're looking for when you're performing fundoscopy in terms of neurologic conditions is in the patient who has painless monocular visual loss. And really, we're thinking, is this person having a central retinal artery occlusion, or are they having a branch retinal artery occlusion, or is it something else? And the main other ophthalmic differential diagnosis not to miss in that context would be a retinal detachment. So they could colloquially be known a CRAO and a BRAO as a stroke of the eye. So some patients may refer to it in that way because that is essentially what it is. And what do they look like on fundoscopy? So basically the part of the retina which is affected, so in the central retinal artery occlusion, it will be most of the retina, or in the branch retinal artery occlusion, it will be a specific part or portion of the retina. The affected retina will appear pale, and the vessels beneath it will be less distinct or may not really be evident at all. And if you're lucky, you may see a visible embolus, such as, say, a cholesterol embolism or some form of atheroembolism in the retina. I can't say that I've ever confidently seen that. That's normally the ophthalmologist that says, oh, look, there's the embolism, but it's something to be aware of and something to look out for. Also, you may have heard of the cherry red spot in a central retinal artery occlusion, and that's actually just the normal fovea, which is the central part of the macula, and that's because that part of the macula is supplied by an alternative blood supply. So it's by the choroid, and so that part of the retina does not look white, whereas the rest of the retina does look white. Conversely, a retinal detachment, which is, of course, an ophthalmic problem as opposed to a neurological problem, but you need to know about it because it mimics a central retinal artery occlusion, for example. The main thing that you will see on fundoscopy there is an elevated grey, wrinkled looking membrane, as if it's a bit of skin which is kind of wrinkled up and shriveled up. That's what it looks like. And I would recommend that you do a Google search and look at some photographs of fundoscopy of patients with all of these conditions, so of papillitis, papilloedema, optic disc pallor, central and branch retinal artery occlusions, and retinal detachments, so that you have in your mind what they look like, so that when you come across a patient with one of these conditions and you're performing fundoscopy, you don't want to be seeing it for the first time then. Next is acuity. So how do you examine acuity? Well, you should use a Snellen chart, ideally. So you can get them on your phone. Just be careful that the size of the Snellen chart on your phone is standardized for the size of your phone screen, because if you have a really big phone screen and you're using a Snellen chart designed for a smaller phone screen, then the letters won't be the same size, so you'll get an inaccurate reading. And make sure that you're holding the chart at the correct distance from the patient. Or more accurately than that, if you have a printout of a Snellen chart or a proper one framed on the wall or on the door frame or something like this, that would be even better. It's important to test each eye individually. That's really important. Some people get that wrong. And it's also important in neurology. We're not really interested in someone's refractive problem and refractive errors. So we want to test corrected acuity as opposed to uncorrected acuity. So if the patient wears glasses for distance for reading, then they should be wearing their glasses. And if someone has impaired acuity and you suspect that it is because of a refractive error, or even if you don't suspect it, you should do this anyway in case it is owing to a refractive error. You should try and correct it anyway with a pinhole test. So ideally, you would have a little eyepiece with a number of little holes in it. And what that does is it prevents the light from coming in a big burst at all different angles, and it forces the light to just come through in a few parallel streams of light. So it gets rid of the lens's difficulty in terms of refracting that light so that it's focused on one nice spot on the retina. So it's a way of circumventing that refractive error. If you don't have that equipment with you, you can try and make a makeshift pinhole by getting a piece of paper and poking a hole in it and using that as the pinhole. You can sometimes get by with that, but it's pretty tricky to do and pretty suboptimal. So it is better if you just have the proper eyepiece with lots of holes in it. And it's not uncommon that you'll examine a patient who appears to have quite impaired acuity, and then you correct it with a pinhole, and then suddenly it's fine. And so it was really just a refractive error all along, and it wasn't actually a neurologic problem. So that person didn't have cortical blindness or optic neuritis or something terribly wrong with their central or peripheral nervous system. They just need glasses to correct their refractive error. In terms of actually reporting the acuity, sometimes people get the numerator and the denominator mixed up because counterintuitively the number that changes is the denominator, not the numerator. So in Australia and in parts of Europe, we use meters. So standard would be 6 on 6, 6 meters on 6 meters. And that means that the patient can read at 6 meters what a normal person can also read at 6 meters. Whereas in the United States and some other parts of the world, normal is 20/20, and that's the same thing but measured in feet as opposed to meters. Whereas if someone has 6 on 5 vision, that means that a person can read at 6 meters what a normal person could only read at 5 meters. So that's actually better than 6 on 6 vision. So 6 on 6 vision or 20/20 vision isn't actually perfect vision, which is a misconception. It's actually just average vision, and you can get better than that. So 6 on 5 vision is better than 6 on 6 vision. Conversely, 6 on 9 vision would mean that the patient can read at 6 meters what a normal average person could read at 9 meters. So that would be below average vision. The other thing is in terms of how many letters they get wrong on each line, if the patient gets one letter wrong, you can write 6 on 6 minus 1. But the way that I was taught is that if they get 2 letters wrong or more, then that doesn't count and you don't score them for that line and you have to go the line up. Lots of people ask the patient to start reading the lowest line that they can in order to speed up the process. That's fine some of the time if the person has pretty good vision or you suspect that they have pretty good vision and they can hear you and they can understand you and they're not delirious and they can follow that instruction. Although if the patient has poor vision or you suspect that they may have poor vision or they're old or hard of hearing or a bit demented or delirious, sometimes that instruction just confuses the patient and it actually slows the process down, and it can be faster just to ask the patient to start at the top and just quickly read through, and that is sometimes faster and more accurate. Now, what do you do if the patient cannot read any of the letters on the Snellen chart? So they can't even read the biggest letter, which on most charts from memory is the equivalent to 6 on 60 vision. Well, you then move to counting fingers. So can the patient count your fingers? If they can't do that, you ask, can the patient detect movement? So to do that, you just move your hand and then you stop moving your hand and you see, can the patient distinguish between those two things? And if the patient can't do that, you then establish whether the patient can distinguish light from dark vision. So can they tell that the room is light at the moment because the light's on with one eye open, the eye that you're examining? And conversely, you turn the light off so that it's a dark room and you see, can the patient tell the difference? And if they can't, then they're completely blind. I remember that when I was in 5th year medical school, I had a mock OSCE examination, and the patient was a cranial nerve examination, and I was doing an exam, and the patient was completely blind in the eye, and they couldn't even determine whether the room was light or dark. And I thought, my goodness, what is going on here? And it turned out that, unbeknownst to me, the patient actually had a glass eye, and the prosthesis was so realistic that it wasn't immediately obvious that it was a glass eye, and it was this trick that this patient liked pulling, and the examiners organizing the examination like to bring that patient in to trick people and to demonstrate how realistic eye prostheses can be. So don't be fooled by that either. Now, the next step is visual fields testing. So this is done via confrontation. And again, it's imperative that you examine each eye independently. I've seen so many people examine the eyes together and you're not testing each eye individually in that case, so it's not particularly helpful. And you also have to think about where you're positioning yourself and whatever instrument you're using to test the fields in relationship to the patient. So ideally, you'll have your head at the same level of the patient's head, nice and perpendicular with straight ahead actually with the patient at eye level. And then you need to introduce in each of the 4 quadrants for each eye, the stimulus in the corner of the visual field so that it's coming in equidistant between you and the patient so that you're doing a fair comparison between what you can see and what the patient can see. All the textbooks and the examiners in the past have always recommended using a hat pin. If you don't have a hat pin, it is completely fine just to use a finger. That's what I do all the time. I don't think it makes a significant difference. I have compared them. Maybe there's a tiny difference, but I really don't think it's a significant difference. I think it's okay to use a finger. Although in an examination, it would be better to use a hat pin because the examiner might expect you to do that. And so you do one at a time, come in from the side, and then the side here. And then I see lots of people doing this thing where they cover one eye and then they use their contralateral arm to come across the frame to come in across from the other side. I don't understand why people do that because as the examiner, you can just close your own eye and use both hands. So you can just close one eye and then just use this hand to come in and this in and this in and this in. And a way that you can do it even more efficiently, I think, is rather than just coming in like this, you can just start right out at the end of the visual field and then where you can yourself only just see it, and then you can just move your hand. Sorry, I'm probably out of the screen of the camera right now, so you probably can't see this, so I'll do it so it's in the camera. Just move your hand and just see if the patient can tell you accurately which side is moving or not. And that way you know the patient's not guessing because they have to correctly tell you which side is moving. And the other main advantage of that strategy is you can then test for visual neglect at the same time, which is quite important. Whereas if you're doing one side moving in and then the other side moving in, then you can't really test for neglect. So because you have to test with bilateral confrontation. What else is there to say about fields testing? The other thing to say is that it's really common for the patient to not look straight ahead and they actually deviate their gaze and look where you're testing. And you're therefore not actually examining the patient's visual fields. You're just testing their ability to deviate their gaze to look directly at your finger with the center of their vision. So if the patient looks at your finger, you have to say, no, look at me, look at my nose. I'm testing your peripheral vision, look at my nose, and then tell me which hand is moving in the corner of your vision. And you may need to redirect that patient 3 times, 5 times, 10 times, 20 times if it takes 20 times until they're truly looking at your face. One exception to that is in the hyperacute stroke context, in which that can just take too long and you're killing too much time, you're losing too many neurons per minute. So if the patient is consistently deviating their eyes towards the side that you're moving your hand, then you can infer from that that the patient is actually able to see your hand moving in the corner of their vision, and that's how they know to then defer their eyes in that direction. And the only exception to testing the eyes individually, I would argue, is in the hyperacute stroke context where you're really interested in, does this patient have a large posterior or perhaps anterior circulation syndrome, which could be knocking off some of the optic radiations as opposed to causing cortical blindness in the posterior circulation necessarily. But you're not really interested in distinguishing monocular from binocular vision if someone's also got a hemiparesis and a dysphagia. It's a bit different if you're thinking about a central or a branch retinal artery occlusion, but if you've got someone who's got a niece of 20 and they're dysphasic and hemiparetic, I would not recommend wasting time testing the eyes individually. I would recommend just doing a quick bilateral visual field assessment to determine, does this person have a homonymous hemianopia or not? Optometrists and ophthalmologists can do more formal visual field assessments by using the formal Humphrey visual field testing mechanism by using a computer system, but obviously we don't have that availability by the bedside, and it's not within our scope of practice either. Lastly, in terms of the second nerve on its own, there is color vision. So, when is color vision relevant? So, in neurologic practice, it's really again looking for pathology of the optic nerve, often in the context of optic neuritis, especially an inflammatory demyelinating optic neuritis, such as in the instance of a clinically isolated syndrome or multiple sclerosis, for example, or some other forms of optic neuropathies. And there's two ways to do this. The better way is to have Ishihara plates, which are a standardized set of plates which have different numbers usually, which are in one color and then the background's in another color. And the amount of contrast between the foreground and the background varies for each of the plates. And you keep doing it until the patient can't determine what the number is. So they can't accurately distinguish the foreground from the background, because their ability to detect color is insufficient to then make that differentiation, and then you can score them based on which plate they got up to. So that's the most accurate way to do it. If you don't have Ishihara plates on you, although you can just get them on your phone again, a more quick and dirty way to do it is just to make a gross assessment of their red color desaturation. So you can find something in the room which is red, like an alcohol bottle on the wall or a red pen or anything else really which is red, and just ask them to close one eye, look at it, see if it looks like a normal red color or not, get them to test it in the other eye, ask the same thing, and then ask them to compare the two sides. And if they say, oh, one of them looked like a washed out faded pinky color and the other side looked like a proper red, then that's a gross assessment of the patient having color desaturation or impaired color vision to red in one eye. So now we're combining the second and the third nerve, the optic and oculomotor nerve, to examine pupillary reflexes. And firstly, we're turning to the light reflexes. So the afferent limb with an A is mediated by the second nerve, and the efferent limb with an E is mediated by the third nerve. And some pearls in regards to examining the light reflexes is whatever light source you're using, whether that be a pen torch if you have one, otherwise just using the light on a smartphone, I think is completely acceptable. You just need to make sure that you're not inadvertently lighting up both eyes when you think that you're only lighting up one eye. So make sure that the torch or the phone or whatever the light source is really quite close to one eye and not angled so that it's actually lighting up both eyes. I have seen lots of people examine and they're shining it at such an angle that they think they're lighting up one of the eyes, but they're actually lighting up both eyes. And you need to examine the direct light reflex, so what happens to the pupil that you're shining the light in. And then you also need to examine the consensual light reflex, which is what happens to the pupil in the eye that you're not shining the light in. Because, of course, the efferent limb of the reflex affects both eyes. So when you shine light into one eye, both pupils should constrict. Next, I routinely test for an RAPD, a relative afferent pupillary defect, which is also known as the Marcus Gunn pupil. And there's quite a bit of misunderstanding as to what an RAPD actually is. So it's really a test predominantly of optic nerve function, although you can get an RAPD if there's any reason why light that's hitting the front of the eye is not getting into and then being transmitted along the optic nerve as well as on the contralateral side. So there are ocular pathologies such as in the retina or more anterior to that can also cause an RAPD, but in neurology we're really talking about the optic nerve. And the relative is important because what we're assessing is how good is one optic nerve relative to the other one. And so what we do is we shine the light into one eye, and then with the swinging light test, we then swing it across to the other eye. And so what we know is that we swing it into the first eye, that should cause both pupils to constrict. and then you swing it across to the other eye. And as you're swinging it, there's no light in either eye. So both pupils start to dilate again. And then by the time you get to the second eye, it shouldn't have dilated completely yet because you should have been fast. And so when you get to the second eye, it should then constrict again quickly. However, if the patient has an RAPD, instead of constricting again quickly, it continues to dilate for a period of time, maybe a second or a few seconds, before it then realizes what's going on, and then it starts to constrict again. So there's that delay. Whereas if a patient does not have an RAPD, what should normally happen is you put it on the first eye, both pupils constrict, you then swing it across to the second eye. When there's no light in either eye, both pupils start to dilate. And then by the time you get to the second eye, it just quickly constricts again, and there's no delay or asymmetry. The main trap to fall into here is not swinging the torch quickly enough. So you really have to be pretty quick, because if you take too long for the torch to get to the other eye and it's already essentially dilated completely, you're too slow and you've missed the window of opportunity to assess whether there's an RAPD there or not. So in terms of the actual speed, it really has to be swinging quickly like this if you're watching on video, or I'll maybe describe it as being at roughly 2 hertz, I suppose. So in about half a second, you should be getting across to the next one. So it should be left, right, left, right, left, right, like that. So it really has to be quite quick so that you're getting there in time to assess for whether there is an RAPD present or not. That's a very important sign to elicit, especially in the patient with suspected optic neuritis or other forms of optic neuropathies. The other pupillary reflex which can be examined for is the accommodation reflex. I can't say that in clinical practice this is routinely very helpful, although it is something you need to know about certainly. And the reason for that is if pupillary light reflexes are impaired, so the pupil is not reacting to light, but if the accommodation reflex is normal, then that results in something called light near dissociation. So that means there's a dissociation between the pupillary reflex when it's exposed to light versus a near stimulus. So it's not working to light, but it is working to a near stimulus. So it is working to accommodation. And that dissociation is very significant clinically, and it's also known as the Argyll-Robertson pupil. So if there is an Argyll-Robertson pupil or a light near dissociation, then that tells you that there's a midbrain lesion, typically involving the Edinger-Westphal nucleus. I'll say that again, the Edinger-Westphal nucleus, or very close to that with some of the associated connections to that nucleus. And classically, the cause for that is neurosyphilis, tertiary syphilis. There are some other causes, but that is the classical cause. That comes up in examinations all the time, and it's an important thing to know about, especially given the rise of syphilis in some parts of the world, including in Australia. So that's an important thing to know about. So especially if there are other features of neurosyphilis, or if pupillary light reflexes are absent, then certainly you must assess for an accommodation reflex. Although I would argue that if the light reflexes are normal, or if there's no high clinical suspicion for neurosyphilis or a different form of a midbrain lesion, then the clinical utility of also assessing accommodation reflexes is pretty low, so I don't routinely examine that. Next is ptosis, which is really just an examination of the third nerve, and specifically is the levator palpebrae superioris muscle. The reasons that someone can have a ptosis owing to weakness of the levator palpebrae superioris muscle is from a third nerve palsy, or it can be from dehiscence of the muscle from the tarsal plate, such as in benign age-related dehiscence, or from trauma or other forms of dehiscence, or in the context of neuromuscular junction disorders such as myasthenia gravis, or in a number of myopathies that have facial involvement. The other way, neurologically, that you can get ptosis is from weakness of the other muscle, which is involved in keeping the eyelid elevated, which is the superior tarsal muscle, also known as Mueller's muscle. And rather than being innervated by the third nerve, that is innervated by the sympathetic fibers that come directly from the superior cervical ganglion. And of course, that's important in the context of Horner's syndrome. But the important way to distinguish between the two, and by the two I mean, say, a third nerve palsy causing ptosis from levator weakness and a Horner's syndrome with sympathetic fiber involvement causing a ptosis from superior tarsal muscle weakness, is what is the pupil doing? So, as we all know, in a Horner's syndrome, you get the triad of partial ptosis, meiosis, and anhidrosis. It's pretty hard to examine for anhidrosis, but the pupil is the key. So you should have a small pupil, meiosis. Whereas in a third nerve palsy, you should not have meiosis. And conversely, if it's what we call a surgical third nerve palsy, then you get the opposite. You actually get mydriasis, or a big pupil. And classically, that's because the fibers in the third nerve that control the pupillary muscles are located on the outside aspect of the nerve. So if you've got some form of surgical pathology like a PCOM aneurysm or a mass or a bleed causing compression, extrinsic compression, then that's going to be compressing the nerve from the outside. And so it's going to be affecting those fibers on the periphery of the nerve. And so you get pupillary involvement. Whereas if you have a pupil sparing third nerve palsy, such as medical third nerve palsy, maybe that's diabetic third nerve palsy or some other cause, then you may not have involvement of those peripheral fibers on the outside of the nerve, so you may not have pupillary involvement. But that was a long way of saying that that's one key way of distinguishing a patient with ptosis owing to a third nerve palsy from ptosis owing to a Horner syndrome. And classically, because the levator is the more important muscle of the two, the ptosis will be more prominent in a third nerve palsy, whereas it may only be partial in a Horner syndrome. Now let's move on to the third, fourth, and sixth nerve together. So that's the oculomotor, the trochlear, and the abducens nerve. So the main thing to examine here is the extraocular movements. So that's examined again by looking at one eye at a time, although if you're quick, you can just do them together. If someone has a problem, it can be helpful to cover one eye and then cover the other eye and test each eye individually. Although if there's not a difficult case, then you may not need to do that, and you can just have both eyes open and do the H. And as the examiner, you just need to be quick enough to be looking at both eyes as you're going along to make sure that both eyes are moving normally in each of the directions. And the reason that we do an H appearance, so we're looking to the right, top left, bottom left, and then back across to bottom right, is because they are the 6 primary directions of gaze, which are controlled by various combinations of the 6 muscles that control extraocular movements. So, of course, they are the superior and inferior and lateral and medial rectus muscles, and also the superior oblique and the inferior oblique. With each movement, you need to assess whether the patient has diplopia and also whether there's any nystagmus present. Regarding diplopia, it is a bit slow to say. Are you seeing double vision here, here, all the time? It gets a little bit tiring. I sometimes, if I'm not really concerned about an ophthalmoparesis or an ophthalmoplegia and diplopia, I'll just examine all 6 directions and then at the end say to the patient, were you just seeing one finger the whole time? And if they say yes, then that's good enough for me, and I don't think that there's any evidence of diplopia and ophthalmoparesis. But if I'm particularly concerned about a third, a fourth, or a sixth nerve palsy or some other form of ophthalmoparesis, then I'll be slower and more deliberate and ask for diplopia in each of the 6 primary directions of gaze. And then the nystagmus testing is more relevant for a number of brainstem and cerebellar and vestibular pathologies, which we'll get to later. Now, in terms of remembering the relevance of the different nerves to the different muscles, all you need to remember is that the third nerve does everything apart from two of the muscles. And the way to remember it is that the superior oblique does the fourth nerve and the lateral rectus does the sixth nerve. So if you remember SO4, LR6, then you're good. And that's all you need to remember. And in order to remember SO4, LR6, maybe you can come up with a better idea than this. But for some weird reason in my mind, I always think so SO4, so for you, so in it for you, I'm so into you. I don't know how I got there. That just somehow came into my mind and I've always just remembered it. So if you remember, I'm so into you, so for you, superior oblique 4. And then the other one, the odd one out, is the lateral rectus, which is the sixth nerve. So the other thing to remember is that contrary to the name, based on the biomechanical properties of the anatomical positioning of the superior oblique muscle, which wraps around the eye, the superior oblique actually pulls the eye downwards, not upwards. And the inverse is true of the inferior oblique muscle, which actually pulls the eye upwards, not downwards. And the other thing is the superior oblique pulls the eye inwards, so it intorts, so it depresses and intorts the eye. And then in order to remember what the sixth nerve does, I relate that to the pathology. So I just remember that a sixth nerve palsy causes failure of abduction, abduction. And the other way to remember that is another clinical point to remember, which is to beware false localizing signs in terms of a false localizing sixth nerve palsy in the context of raised intracranial pressure, I should say. So classically, if there's a supratentorial mass lesion causing downward pressure, that can cause stretching of the sixth nerve over the bony structures, and it can cause pathology or dysfunction, I should say, of the sixth nerve without the actual site of the problem, the primary site of the problem, having anything to do with the sixth nerve or the nucleus of the sixth nerve in the pons, in the brainstem. It's a problem which is remote to there. Maybe they've got a big tumor or a bleed in the supratentorial region, but it's causing dysfunction of the sixth nerve, so it's a false localizing sign. And in particular, if you have bilateral apparent sixth nerve palsy, so neither eye can abduct, then that's a classic false localizing sign, and you really need to think, does this person have raised ICP? Does this person have a mass lesion, especially a supratentorial mass lesion? So again, that's how I remember it. SO4, LR6, so into you, so for you, and then lateral rectus 6 is the other odd one out, which is the one you need to remember in false localizing signs of a sixth nerve palsy with failed abduction. Or, of course, you can have a true localizing sixth nerve palsy, which, of course, also causes failed abduction. Now, the other things to look at in terms of extraocular movements are examining for an INO, an internuclear ophthalmoplegia. And this is really relevant, particularly in a neuroimmunology assessment in an MS, a multiple sclerosis assessment. So the way that you do this is you test the patient's horizontal saccades. So you get the patient to look to the left and then you ask them to quickly look to the right and back again. I've seen some people ask the patient to look to the left and then the middle, left, middle, and then right, middle, right, middle. I think either is fine because in both instances, you're just assessing the patient's horizontal saccades, so you're getting the same end result. And it's important that they are moving their eye quickly because you're testing saccadic movements, not smooth pursuit movements. And you can, for instance, say, have a finger on the right and a fist on the left and say, look at my finger, fist, finger, fist, finger, fist, or you can click on one side and then click on the other side, click one, click on the other. It doesn't matter how you want to do it, just so long as the patient's doing what you need them to do. And what are you actually assessing for? You're assessing for damage in the MLF, the medial longitudinal fasciculus. And this is a white matter tract which can notoriously be implicated in a demyelinating lesion in the context of multiple sclerosis. And what does an INO actually manifest with? Well, I remember that this is one of the horizontal tests that we're doing, but it's basically the opposite kind of a sixth nerve palsy. So a sixth nerve palsy, we just agreed, causes failed abduction, whereas an INO is essentially the opposite of that in terms of remembering what it looks like. So it causes failed adduction. So the eye which is affected by the INO, the eye cannot adduct. And in addition to that, you get this compensatory contralateral nystagmus when the other eye abducts. So if you can imagine that the patient is looking to the right, and then you ask them to quickly look to the left, if they had an INO in their right eye is trying to move to the left, but it can't adduct all the way, so it doesn't make it all the way across. It might just go to the middle and not make it all the way across. Whereas the left eye moves to the left, so it's abducting, and it gets this nystagmus whilst it's in the abducted position, so it will be beating to the left when it's moved to the left. So that's what an INO is, which is strongly suggestive of damage to the MLF, especially in the context of, for example, demyelination in the context of multiple sclerosis. The other thing that people often like to comment on, which I don't think is super helpful a lot of the time, but it's a good thing to take note of if it is present, because it is a helpful thing to look at, is are there saccadic intrusions into smooth pursuit? Or are the saccades slower than you would expect them to be? So what that means is when you're doing your H testing and you're getting the patient to do smooth eye movements, instead of them being smooth, are they actually jerky? So that would be saccadic intrusions into smooth pursuit. Or alternatively, if you specifically test saccadic testing, such as when you're testing your horizontal saccades, and you can also examine vertical saccades, so get the patient to look up, down, up, down, up, down, are those eye movements just generally slower than you would expect them to be? And that can be a sign of brainstem or of cerebellar or vestibular pathology. And it's particularly relevant in the context of neurodegenerative conditions, such as those affecting cognitive domains and those affecting the extrapyramidal system. So, what I mean by that is it's relevant in the context of various dementias and various Parkinson's disease or Parkinsonian like syndromes. You often see these saccadic intrusions into smooth pursuit or slow saccades. The reason I don't think it's super helpful a lot of the time is it's just very non-specific. I can't say that I've ever made a clear diagnosis of one particular condition or another on the basis of the presence or the absence of saccadic intrusions to smooth pursuit. And I can't say that it's ever really influenced my diagnosis or my management or even my investigation plan. So I wouldn't say that it's the most important thing to look at in the cranial nerve examination, but it is still something to take note of, and it may put you more in one direction or the other if you do notice their presence or their absence. Now, I've actually decided to split this episode up into two parts because the first half of the episode took a bit longer than I anticipated, and I want to assist in everybody's retention of the information, and I don't want to overburden you with too much. So, thank you so much for tuning in, and the next episode will be the second part of the theory of the cranial nerves assessment, where we will address in detail the other cranial nerves. So thank you so much for tuning in. I really hope that you've learned something today. Please like, comment, and subscribe if you found this useful. Visit rneurologyeducation.org for all of our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms at the domain R Neurology Education, and that's R for the letter R. Also, please email us on contact@rneurologyeducation.org with any questions that you may have or to subscribe for updates when new content is released. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.